every rib is an artery, a vein, and a nerve. So we always ride over the rib and then place the needle in the pleural space. And then remove the needle, leaving the catheter in place, and secure it. It also, leaving it in place, even if it becomes obstructed, it helps to let the hospital staff know that decompression has been performed, or how many have been performed if you have a couple of them next to each other. So you may have to perform a second one. For circulation, we're going to recheck and control all bleeding. Placing compression bandages if you have a significant injury to an extremity that you placed a tourniquet on. This is the time where we're actually going to bandage that wound with a compression bandage or cling or whatever you consider. The options for the compression bandage is the bulky Kerlix that we carry, or a 5x9 pad with an ACE wrap bandage that we'll go over a little later. The other option is the Israeli bandage. This is a pre-made compression bandage that has a large pad attached to it, to the elastic bandage. It also has a pressure bar to apply a little extra pressure over that wound. There's the option for wound packing these injuries, especially to extremities. And then reassessing these tourniquets, are they still effective? Once we place a tourniquet, because we're in the urban setting, the patient's going to be to definitive care, hopefully in less than an hour. We're not really going to do tourniquet conversions or rotating tourniquets or any of those things that you may see in the extended care austere environment or in the battlefield. And then we're also going to evaluate head injuries, eye injuries, abdominal injuries, and evisceration, open abdominal injury, burns, and then pelvic injuries. We carry the SAM pelvic sling to stabilize suspected pelvic fractures, and it's best to place that before the patient is immobilized on a backboard. It's a lot easier to get it onto them before they're secured to the backboard. And then there really needs to be an emphasis that transport should never be delayed to establish an IV. If the patient is hypotensive and showing signs of shock, the IV is only going to prolong or delay the treatment that they need, which is definitive surgical care. So these patients should not be sitting on scene in the back of the ambulance. Once they get in the back of the ambulance, they should be en route to the hospital. And if help is needed, then obviously more people can ride in and get those IVs en route. For head-in hypothermia, we're going to assess the AVPU and GCS to identify potentially any closed head injuries. For hypothermia, reemphasis, prevention is the key. Keep these patients warm. If it's a February night that's rainy and the patient's laying on the wet ground, just getting them up off the ground on a backboard will really help to prevent them from losing body heat through the ground. Removing wet clothing and then covering the patient with a blanket, even just the yellow highway blanket will do a lot to just get that wind chill off of them. Hypothermia increases the risks of coagulopathy, the body's inability to form blood clots. Risk factors include trauma, alcohol, the environment, and age. And a lot of those are multiple of those are considerations during a lot of our traumas. During the transport phase, we're going to reassess on-scene interventions that were performed, airway management, tourniquets, definitive airway control. This is the time to do that if we need to do an RSI. This is where we're going to do the detailed head-to-toe exam, not just the blood sweep, identifying the March principles, but now we're going to do a detailed head-to-toe exam. Establish vascular access. The target for the blood pressure is 90 for patients, especially patients with head injuries. We don't want the blood pressure to get below that. For other trauma, there's a lot of science and evidence out there suggesting permissive hypotension and allowing the patient's blood pressure to be a little lower, which is a natural body response to trauma to decrease the pressure on newly formed clots. It also, hypotension stimulates the liver to release clotting factors into the bloodstream. We don't want to artificially increase the blood pressure with normal saline, which is typically cold below the core temperature of the body. It does not transport oxygen and essentially just dilutes blood. So we need to be cautious with our fluid challenges. Fluid challenge should be for hypovolemia. Really, it's just to reverse the signs and symptoms of shock. For pain management, fentanyl is our main pain medication that we carry in Clark County. It has a very wide safety margin, not like morphine that had the tendency to drop the blood pressure. Fentanyl has a much more safe margin. And so with patients with trauma, we can consider giving small amounts of fentanyl and titrate to effect and to blood pressure. Pain management is associated with better overall patient outcomes. There's been studies that have shown that pre-hospital pain management has contributed to shorter hospital stays and less overall pain medicines that the patient required during recovery. During the transport phase, we want to do splinting for any fractures, dislocations, and then treat for shock. So just to recap, the goal really is pre-surgical care, not just pre-hospital care. And we want to save red blood cells, save every red blood cell. They transport oxygen, they transport all of the things that are going to prevent this patient from going into shock. Shock really is global tissue hypoxia secondary to hypoperfusion. So we want to increase perfusion and really increase oxygenation for a patient that's in profound shock. They may need their airway secured and they need to be ventilated by a BVM to increase their oxygenation. And then we want to prevent the lethal triad. That's coagulopathy, hypothermia, and acidosis. These things work together and compound each other. So we really want to prevent all of them. So the changes to the trauma kit that we've made, it really for a long time was considered a BLS kit and for the most part was left on the rig. It really is a standalone trauma kit, specific trauma kit. Things that have been removed from it are the IV supplies and the BLS meds. Those meds are now carried in the medical kit as well as the IV supplies are in there. With it being there being an emphasis on the trauma supplies, we've added more bleeding control equipment and chest decompression needles have been added to the trauma kit, taken from the airway bag and put in the trauma kit. We're going to go over these changes here in a bit later on in this class. For the triage bag is kind of based on the March principles that we went over. And the triage bag now has tourniquets, Israeli bandages, wound packing gauze, and chest decompression needles, as well as the triage equipment and some extra airway adjuncts, MPAs and OPAs. This is a bag that you don't need to wait for that multiple patient scene or MCI to grab this bag. This bag can be carried, to any trauma, obviously, and it's going to just complement the trauma kit because it's carrying the same supplies. So you'll have more of it if you do have multiple patients. Okay, now we're going to be talking about the changes that we've made to the trauma kit. One of the things we did is have labeled the kit with a reflective labeling just to help identify, one, the kit and the unit that it belongs to, but then also we're going over, or this helps if there's multiple units on scene and we're operating out of this kit, it could possibly help with identifying what unit is in a treatment area. So there's labels say fire and then the unit designation, this being Rescue 2. So some of the changes that we've made are removing all of the IV supplies, IV fluids, and then also all the BLS meds have been pulled out of the kits. And then burn sheets, just to make room for the trauma supplies that we've added, and then being able to carry more. So in the main compartment down here in the back, we've got 2 of the large trauma bandages. Some of the kits still have burn sheets, 1 burn sheet and 1 trauma pad, and I really don't know what is the better option, but on the inventory list, it shows 2 trauma pads of the large trauma pads. And then there's a pair of eye protection. These are for the rescuer, but then also can be used for the patient to manage an eye injury, and we'll talk about that here in a little bit on ways that you can do that. And then there's a bottle of sterile water for irrigation in the back here. And then we have ACE wraps. This is an elastic bandage that has a Velcro closure on it. There's 6 of the 6-inch wraps, and then there's 6 of the 3-inch wraps. And they both are the same length, just a different width. This is the Israeli bandage, and I'll open one up and show a couple different techniques on how to use it. It's a 6-inch bandage. It actually is called the emergency bandage or trauma wound dressing, but it is affectionately known as the Israeli bandage. That's kind of the common term. A lot of the local law enforcement carries this bandage as well, so it's a common bandage that you might see out there. And then there's one of the burn face masks. This is to place on a patient that has a burn to the face, and it's almost like a ShamWow. What you can do is open up the packaging and pour in some sterile water, sterile saline, and that'll kind of permeate the mask, and then the mask can be placed on the patient. Also in this pocket is 4 5x9 gauze pads that can be used for making a compression bandage or whatever else. We've got some ice packs, and then a stethoscope and BP cuff here in this pocket. And then we've got the wound packing gauze. It comes in 2 different packaging. One is called the Z-Pack dressing, and it's 4.5 inches by 4.1 yards. It's just gauze that's basically Z-packed into this rather than rolled like a Kerlix bandage. The other one is the S-rolled gauze. So it's just different manufacturers, but essentially is the same thing. Once you open up the vacuum sealed bag, there's a smaller pouch that the gauze is in. You can take it out almost like a ribbon and start stuffing it into the wound. And that'll protect the rest of the gauze so it doesn't get dirty or bloody on the ground. And then we have 2 of the combat application tourniquets. These are field stripped, removed out of their plastic packaging, and really the tab should even be over, because if we're placing a tourniquet, time is of the essence, and we want to be quick. So we're gonna place this tourniquet fast. We don't want to take the time to have to remove it out of its plastic packaging. So there's 2 tourniquets in here, ring cutter and some Coban. On the front page we've got alcohol preps, some surgical lubrication, helpful for removing rings or other jewelry. We've got some 1-inch cloth tape and 2-inch cloth tape, a pen light, a few extra pairs of gloves, some hand clean wipes and Band-Aids. On the back page we've got just the standard Kerlix rolls, 4 of those, 4 triangular bandages, got eye pads, some medical razors for shaving the chest if we need to apply a chest seal, and then iodine to prep the chest if we're going to do a chest decompression, and then a 10 gauge or 10 cc syringe for aspiration when we're doing a chest decompression. Got a handful or stack of 4x4 gauze back here, 2 chest decompression needles. This is the ARS needle. It's made by North American Rescue Products, and it's a 14 gauge needle, 3¼ inches long, and it's in this nice protective container. And then it's also a reinforced catheter, so it's not going to potentially bunch up on the chest when you're trying to insert it into through the skin and through the muscle. So it's a reinforced needle specifically made for chest decompression. And then over here we've got the Asherman chest seal. You may have 2 Asherman chest seals. You may also have an expired defib pad in your trauma kit if somebody's placed one in here. So that's where the chest seals are going to be. So that is the layout of the new trauma kit. And then for the triage bag, we've got 2 of the CAT tourniquets plus a ratchet tourniquet, which is a little bit longer. And then we've got wound packing gauze, either the S-rolled or the Z-pack dressing, Israeli dressings, some 5x9s, some airway adjuncts, and some chest seals in there, along with all the triage tags and such. Okay, now I'm going to be going over some of the specific supplies and how to use them that we have new to this kit. So first we'll talk about the Israeli bandage. On the packaging it says the emergency bandage. It's also called the trauma wound dressing, but its main name that it's known by is the Israeli bandage. Like I said, a lot of the local law enforcement carries this bandage. Officers are carrying them in their individual first aid kit that might be on their external body armor in a container, and then also a lot of them have a tourniquet. So in this packaging, it's vacuum sealed, so once you tear off the tab, it's open, but it's not really open yet. The bandage is then in a clear packaging, so you have to open that up as well. And then you have the bandage. It's an elastic bandage, and when you first unroll it, you have your pad. That's basically a 5x9 gauze pad that's attached to the bandage. And then there's a piece of thread that's through this roll, so that if you were to let go of it, it's not just going to unravel and get into the mud or whatever else. So that string is really easy to break. And then the bandage on the top, it has this pressure bar, and I'll show you how to use this. This just helps to apply more downward pressure on the wound when you're controlling bleeding. And then at the end of the roll, there's a plastic closure bar to secure the bandage in place. There's a couple different ways to use this bandage, and it's pretty beneficial for controlling bleeding, especially on extremities or the chest, and controlling bleeding on amputations. It's pretty effective. So the other option for a compression bandage is the ACE wrap that we carry. This is the 6-inch wrap. We also carry the 3-inch wrap. It's in a plastic packaging. The best way to open this, rather than kind of picking on the ends, is just twist it and pop it open on this red line here. And it just pops open, and then you can slide the bandage out. So you may use a 5x9 or some of the wound packing gauze on the wound as the bulky dressing, and then we're going to use this ACE wrap as the compression bandage. And with a new bandage that has not been used yet, it's got a lot of elasticity, a lot of stretch to it. So you can wrap the bandage up, and then at the end of it, there's a Velcro closure that you can use, or there's a few other techniques to secure that in place that we'll talk about. For the wound packing gauze, we have the Z-pack dressing or the S-rolled gauze, and this again is vacuum sealed. Once you open it up, the bag, or the outside packaging, then there's this smaller bag that's inside. It's a clear bag. And then the gauze is just in here, just stuffed in. So you can start to pull it out, and as you remove it from this packaging, you can stuff it into the wound, and we'll have a video to show you that particular technique. And this packaging just gives you the ability to keep the dressing clean until it's in the wound. Or you can just remove it all out of the bag and just have a large bulky dressing that you can stuff over the wound and hold in place. And that's going to just give you a lot of gauze to control bleeding, to then bandage over with a compression bandage. The next thing we're going to talk about is the tourniquet. This is the combat application tourniquet. Blue is for training, out of our training kit. The tourniquet that's in the trauma kits is black. Those ones should not be used for training. If you want to train with one, you can request these through the trained division and play with the blue ones. The makeup of this tourniquet is there's an internal strap that runs from end to end, and that's what tightens with the